The lecture is on evidence-based management of recurrent pregnancy loss. This lecture will be presented by Professor Salam Jibril, who is working in Arabian Gulf University. He is a consultant obstetric and gynae with special interest in minimal invasive surgery and reproductive medicine. Dr. Salam, please start.
Thank you, Doctor. Bismillah ar-Rahman ar-Rahim. I hope I can manage this lecture because I was replacing another speaker in the last 2 days. They told me to do my talk about this management of recurrent pregnancy loss. And we'll talk today about comparative things between the oral and the micronized vaginal progesterone supplement, which we use for the recurrent pregnancy loss. And of course, there are different types of pregnancy loss, whether it is early or late, spontaneous. And of course, the recurrent pregnancy loss, usually we adopt the British definition rather than the American definition, which is 3 consecutive pregnancy losses, rather than 2 or more pregnancy losses as the American Obstetrics and Gynecology Association coined that. Of course, most of those pregnancy losses in the early pregnancy are contributed to the abnormal embryos, and those abnormal embryos are structurally abnormal, mostly due to chromosomal abnormalities. And there are other causes like the maternal causes, whether the uterine anatomy or bacterial vaginosis infection, or even some immune deficiency like the antiphospholipids, and of course other endocrine problems. Of these, the luteal phase defect sometimes, and the thyroid abnormalities. And of course, we know that the progesterone supplement for the pregnancy is coming from the corpus luteum, and usually it is after the ovulation with the level of progesterone coming up in the second phase of the menstrual cycle. That's the definitions of the British and the Americans. And for those who are having recurrent pregnancy losses, we usually do the what's recommended for the investigations as the antiphospholipids antibody, the karyotyping for the parents, and we do sometimes hysteroscopy or laparoscopy to find out if there is any anatomical factor, and of course, thrombophilia screen for those cases. And of course, there are different options of supplement or of progesterone for those cases of recurrent miscarriages. Of these are the dydrogesterone. Also, we give them some anticoagulants for those cases who are proved to be antiphospholipid syndrome. And for those who are having infections, we give antibiotics like the clindamycin for bacterial vaginosis, supportive care, rest, vitamins, and all these things. And of course, for those who are having abnormality, anatomical abnormality, we do some surgical correction, whether by hysteroscopy or by other surgical means. And the progesterone, which we use commonly, is the dydrogesterone, and Haas and Ramsey had done one study in 2013. They reviewed 14 studies, and the main result came that there is no evidence of reduction of miscarriages by progesterone, and there is no evidence of reduction by route of administration, whether it is oral, vaginal, or intramuscular. But when they divided it to subgroups, the recurrent miscarriages, it was found that the treatment with the progesterone led to a statistically significant decrease in the miscarriage rate when they have used the progesterone rather than the placebo. Also, the study done by Dr. Zibdi in Jordan, this study, he compared the dydrogesterone with the HCG and the placebo, or the control group, and he had found that this dydrogesterone significantly lowered the miscarriage rate when compared with the control group. It was something like 13.4% compared with the 29%, and it was statistically significant. And of course, there were no adverse effects reported during the treatment in this study. Also, Kumar have done a study, and in his study, he compared the administration of dydrogesterone in early pregnancy, and the outcome was correlated with the T helper cells, number 1, and number 2, the cytokine levels, and it was double-blind randomized study, and women were chosen to be between 18 and 35 years of age. He have chosen that those patients should not have the higher chance of abortions, which comes after the age of 35. And of course, he have chosen the patients who have 3 consecutive unexplained recurrent miscarriages. And the treatment was given for those patients, confirmed that pregnancy is there after they have seen the fetal heart. The patients were enrolled until they were given the dydrogesterone until they were 20 weeks gestation. And in this study, the risk of miscarriage, the miscarriage rate was decreased significantly with the use of the dydrogesterone as compared with the placebo. It was something like 7% as compared to 17%. And the gestational age at delivery, it was around 38 weeks, plus minus 2 weeks, which means that the babies reached to the full maturity level, and the cytokines as well, the concentration did not affect pregnancy outcome. Sorry. Also, there was a systemic review for the recurrent miscarriages, progesterone and dydrogesterone, as by Haas and Ramsey, as compared with a study done by CARB. The data of subgroups analysis of recurrent miscarriages in the first study, they have used 4 different types of progesterone. One of them was dydrogesterone, and the subgroup analysis compared with the placebo or no treatment, and there was a statistically significant decrease in the miscarriage rate in this group, and there were 3 studies reviewed in the CARB group, and there were statistically significant reduction as well in the dydrogesterone group treated patients. And the progesterone, the guidelines given by the European Society for the Recurrent Miscarriages, they recommended the use of dydrogesterone for patients with recurrent miscarriages, and it is said that there is a reduction in the miscarriage rate when they have used the dydrogesterone, and the grade and reference was a consensus-based recommendation. There was another study done by Komaramsi, and this was with the micronized vaginal progesterone, and the aim was to have the endpoint of live birth after 24 weeks of gestation completed. It was a multicentral study done in England and Netherlands, and they have chosen women between the age of 18 till 39. So we have added 4 years more than 35, and that, of course, included some cases of miscarriages due to chromosomal abnormalities. And those cases were given micronized vaginal progesterone in the concentration of 800 milligram per day, divided into 2 doses, and placebo. And treatment was given after positive urinary pregnancy test and no later than the 6 weeks of gestation. And of course, the live birth was not statistically significant between the two groups, the treated group and the placebo group. And the secondary endpoints, there was no significant differences between the gestational age at delivery, the clinical pregnancy, ongoing pregnancy and ectopic pregnancy, and the miscarriages, stillbirth, and neonatal outcome. And progesterone did not significantly increase the gestational age at time of delivery as compared with placebo, if we compare that with the dydrogesterone. Of course, if we compare the study we are talking about, the micronized vaginal progesterone, with the study done by Komar, the study by Komarasmi was done in England, as I said, and Netherlands. Komar's study was in India. There were 36 centers in the United Kingdom contributing to the study, the VERSE study, and 9 centers in the Netherlands. And the other study was in 2 hospitals, Maulana Azad Medical College and Lok Nayak Hospital in India. And the first study was, the treatment was active as compared to placebo, provided by one company, Bissen company, and it was a randomized trial of progesterone in women with recurrent miscarriages, and the other one, the oral dydrogesterone treatment, was during early pregnancy to prevent recurrent pregnancy loss, and its role in modulation of the cytokines production. It was a double-blind, randomized, parallel placebo-controlled. Of course, the first study and the second study, it was a single, the first study was multi-center as compared to the second study, which was a single center, and both had unexplained recurrent miscarriages, the same characteristics, except the first one, they included women after the age of 35, they reached to 39, and both were spontaneous conception. The outcome, the objective of the first study was to look at the live birth after 24 completed weeks. The second study, the outcome was pregnancy outcome and the miscarriages rate at 20 weeks gestation. Of course, the dosage in the first was 800 micrograms of micronized vaginal progesterone, and the second was 20 milligram daily of dydrogesterone, which means 2 tablets of the dydrogesterone. The first one, the route was vaginal, the second one was oral, and they started the treatment, and after they have positive urinary pregnancy test in the first group, and in the second group, it was started after confirming that there is a fetal heart and confirming that there is a pregnancy. And of course, the treatment ended in the first one at the 12 weeks, while the second, the treatment continued until the 20 weeks gestation. And of course, the participants were almost equally distributed between the micronized vaginal progesterone and the placebo in the first one. As compared with the second, there were dydrogesterone, placebo, and healthy control. So the second, the Kumar group, there was a healthy controlled group as compared with the first one. And of course, the efficacy results, no significant difference was noticed between the micronized vaginal progesterone as compared with the placebo. The end outcome was the live birth, the miscarriage rate, median gestational age at delivery, the ectopic pregnancy, and the stillbirth. There wasn't any difference, while in Kumar group, there was significant difference between oral and placebo, the miscarriage rate, and in the mean gestational age at the delivery. We said before it was 38 weeks. The safety and tolerability, there were no difference adverse effects between the groups, no difference in neonatal outcome in the first study, and between the groups in total, 2.5% of the babies as compared between the vaginal progesterone, the placebo, and the control. And of course, no significant difference between groups in the rate of obstetrical and neonatal adverse effects. As well, in the Kumar group, there were no adverse effects, in the neonatal outcomes. And dydrogesterone showed a trend to not significant towards reducing pregnancy complications, such as preterm delivery, cesarean delivery, and low birth weight, and small for-date babies. And of course, between the two studies, the choice of progesterone and route of administration was different. The stage of pregnancy was different. The high-risk population and the treatment duration was different. And the enhanced progesterone effect and the produced stable effects and the increased peak systolic velocity was in favor of the oral dydrogesterone study. And of course, we know that most of the pregnancy losses occur, and there are 30% due to failure of implantation, and 30% in the early pregnancy, and 10% due to miscarriages, and then 30% at the live birth. In the Kumar group, there were more likely to be at least 6 weeks pregnant, presence of fetal heart. So there were confirmation that there is a pregnancy, while the other group, they only tested urine and started the treatment after that. Of course, the other thing is that the age of the women included in the study, in the Kumar group, the age was less, so that more of healthy, less chromosomal abnormalities were involved in that group as well. Again, the treatment was only up to 12 weeks of gestation in the first group, while in Kumar group it was up to 20 weeks gestation, and there was no significant difference between the micronized vaginal progesterone and the placebo in the study in the live birth, the miscarriage, the ectopic, and the stillbirth. But in the Kumar group, there was statistically significance in the miscarriage rate and the mean gestational age at time of delivery. So the choice of progesterone and route of administration, use of micronized vaginal progesterone versus the oral, it was the dydrogesterone has enhanced progesterogenic effect and bioavailability as compared with the micronized vaginal progesterone. And the stage of pregnancy as well, women enrolled were early in the Rasmari group, at 6 weeks gestation, confirmed only by urinary test, while women were enrolled in the second group after confirming that there is a fetal heart. And the high risk included in the first group was by the age of up to 39 in the Rasmari group, while in the Kumar group, at the age of 35, recruitment of the patients was stopped at that to minimize the risk of chromosomal abnormalities. Of course, treatment duration, there was a difference in the treatment duration. It was 12 weeks in the treatment of the micronized vaginal progesterone as compared to the oral progesterone. Of course, there were reviewing studies comparing the two progesterones in the cases to prevent recurrent miscarriage. And there were 10 studies reviewed by Sakun, and these progesterones the initial use was to prevent recurrent miscarriages. There were 10 studies included with a number of almost 1,586 patients, and 8 studies were double-blind controlled study, prospective controlled studies. And the main result, there was a reduction in the miscarriages using progesterone treatment given in the first trimester and after 16 weeks. This had lowered the risk of miscarriages, recurrent miscarriages, and higher live birth. And this we noticed in the Kumar group when they have used the oral progesterone. But there was no statistically difference significant with the preterm birth, neonatal mortality, and fetal genital abnormalities. The subgroups analysis showed that there is statistically difference in the dydrogesterone group with oral, with the intramuscular use of progesterone, but there was also no statistically difference when we used natural progesterone and vaginal progesterone. These to compare the 3 studies of progesterone and the data set for the subgroups analysis of recurrent miscarriages between the 2013, 2015, and 2016. And of course, there were 4 studies included in the first group. The subgroup analysis compared the placebo or no treatment with the progesterone treatment showed a statistically significant decrease in miscarriage rate. In the second group, the 2015, the main result was a statistically significant reduction with dydrogesterone as compared with the other groups as compared with the miscarriage and the standard care like the bed rest and placebo, while in the third group there was a reduction of miscarriage by progestogen and a statistically significant difference with using dydrogesterone. Okay, I think we are about to finish. So the ISHRI recommendation for the use of oral dydrogesterone mentioned that there is no evidence that oral dydrogesterone initiated when fetal heart action can be confirmed may be effective. Furthermore, as progesterone is important during implantation of the embryo, benefit from supplementation may be realized if progesterone is administered from the luteal phase, meaning that if we start from the luteal phase early, even before the confirmation of the pregnancy, the result would be even better on the pregnancy outcome. And also the German and Austrian Association, gynecological societies, have mentioned that synthetic progestogens are of value and recommended to be used. The difference between the oral and vaginal, the comparative study done to show that the patients were in favor always of the oral use of progesterone as a supplement to reduce the risk of recurrent miscarriages. The patients, when they have used these medications, the micronized vaginal progesterone as compared with the dydrogesterone, the use of the vaginal route was unfavorable in patients because of the vaginal irritation and discharge, and the tolerability was more in favor of the dydrogesterone as well. Again, both oral and micronized vaginal progesterone are metabolized by the liver, but progesterone is associated with the risk of cholestasis in pregnancy, and there are other effects like the perineal irritation, the vaginal discharge, the interference with coitus, the vaginal bleeding. All were side effects when we have used when the patients have used the micronized vaginal progesterone. And that was seen in the randomized control trial study by Tomek and his group. Okay, in conclusion, dydrogesterone is produced from a natural source. Like other progesterones, it's very similar to progesterone, but has enhanced oral bioavailability, is highly selective for progesterone receptors. It is metabolized into compounds that are either progestogenic or inactive, has a fast onset of action and a stable effect, is well tolerated, and has a favorable safety profile in all approved indications, including pregnancy. And thank you.
Thank you, Professor Salam. I think we have only 2 minutes for one question, and then we'll move to the next subject, please. Any question? Mic there. One question only.
Yeah.
Thank you, Doctor. I just want to ask, that does mean we should be giving dydrogesterone rather than vaginal micronized progesterone for threatened miscarriages?
For recurrent miscarriages, it's preferable to use the oral progesterone, the dydrogesterone.
But then NICE guidelines, they say for the recurrent miscarriages with cervical weakness, the vaginal progesterones are more effective. Either a stitch or a micronized progesterone, which is the vaginal micronized progesterone, is good. So how do we debate on that?
I didn't get
The
that.
second the cervical weakness, when we talk about cervical weakness as a recurrent cause of miscarriage, there is NICE guidelines say that we can give either the stitch, offer the patient the stitch, or the vaginal progesterone. So how does we differ from this
If
one
there
and
is
that
weakness in the cervical musculature, you should treat that surgically, do circulage. It's not the progesterone which will help.
It's there in the guidelines. NICE guidelines say that we can use the micronized progesterone, either or the stitch, both can be done. One of the two, I mean.
Thank you. Shall we call the
I
next
think
speaker?
it's surgical. It's not the micronized vaginal substitutes.
Thank you. Professor
Thank you.
Salam.
Thank you.
It's my great honor and pleasure to introduce my friend, Professor Aris Antsaklis, who is German in Athens, and he's active for many years in obstetrics. He will present a paper dealing with screening and obstetrics. Aris, please.
Thank you very much, Mr. Chairman, for the introduction. I would like to thank my friend Professor Dia, for the kind invitation to participate to this excellent organized Congress. And my talk today is about the next 20 minutes. I'm going to talk about screening obstetrics by ultrasound. Ladies and gentlemen, everybody has, nowadays, all obstetricians, gynecologists, we do have an ultrasound equipment in our office, and we scan patients. But I think we need to be very careful when scanning a patient. So I don't have any conflict of interest, and we know that indication for ultrasound obstetrics is just to diagnose early pregnancy, first trimester screening, everybody knows that. Ultrasound-guided procedures, amnios, CVS, fetal blood sampling, cervical length in order to screen for preterm labor, level 2 ultrasound, just to pick up some malformations, targeted scan for referral patients to you that you are very well educated, fetal echocardiography for special cases, growth scan, and Doppler sonography. So all this gamma of tests you can perform by ultrasound during pregnancy. And the majority of the fetal organ can be visualized early in pregnancy. We know that, and we know that using transvaginal ultrasound equipment and probes, it's very well known that you can diagnose fetal anatomy. But what means screening? Screening refers to tests for detection of individuals at increased risk of particular disorder. Ladies and gentlemen, everywhere in medicine, screening is what I said before. But the screening test has to be simple, easy, effective, profitable, free of undesirable deleterious effects, and comfortable for the patient. Think about what is screening. It's not something very complicated. It's very simple. Has to be simple. For instance, pap smear is a screening test. It's simple. Ultrasound is a screening test, and I'll show you in which way. So we screen the whole population. We perform a test. If the test we say is positive, we proceed to different techniques. If the screen is negative, we don't do nothing. So this is the main idea. So a very short history of screening in obstetrics about chromosomal abnormalities. We started in the 60s, and with maternal age, maternal serum AFP, triple test, quadruple test, nuchal translucency, and nowadays NIPT. So all this progress of screening is just to increase the sensitivity and reduce the false positive rates. It is important that the screening has to be cost-effective. And this implies that the disorder is of high prevalence and that the results improve the outcome. If in a country the disease is not of a very high prevalence, you don't need to screen for this disease. For instance, I know that here in Bahrain, you have a high incidence of hemoglobinopathies. You have to screen for hemoglobinopathies since the prevalence is very high. And since you know what you have to do if you have a patient or a couple with hemoglobinopathies, it's worthwhile to have a screening. So my objective for this presentation is just to review the advantages and disadvantages of the different prenatal screening options and to describe the objective and the results of first trimester ultrasound screening. And first, what is ultrasound screening in obstetrics? Screening refers to tests for detection of individual at increased risk of particular disorders, as I told you before. So, ladies and gentlemen, when you, in your office, you perform an ultrasound test in a patient, low-risk patient, actually, you screen the patient. Since we know that ultrasound became a screening in low-risk population, you have to remember that we have false positive and false negative results. And this is important, ladies and gentlemen, because with false positive diagnosis for malformations, for instance, you produce an anxiety. But you can solve the problem, referring the patient to somebody else, more skilled than you are. But if you have a false negative results and false negative diagnosis, there you do have a problem. And the question is, does routine ultrasound improve the perinatal mortality and perinatal morbidity? Since, ladies and gentlemen, in obstetrics, the key point is to reduce perinatal mortality and morbidity, of course. So, using ultrasound, do we reduce perinatal mortality and morbidity? It's also, there are some other questions. For instance, how good are ultrasound in yielding the required information? How useful is obtaining this information? Can anything be done to improve this? And does the evidence support the use of routine ultrasound to all patients? Or you have to perform ultrasound only in indicated cases? The second question is, when to screen in obstetrics? We know that nowadays, with the evolution of ultrasound technology, along with increasing experience in doctors and increasing experience in couples and mothers, they move screening in the first trimester of pregnancy. Also, women, they prefer that because they do have low false positive rate, high detection rate, what they want women. Timing of results, they have to have early the results, and timing for termination. In some countries that termination is allowed, it's better to perform termination early in pregnancy, not during the second trimester. So we move all the screening tests in the first trimester of pregnancy. But when you perform a screening test in the first trimester of pregnancy, you have to offer also, if there is an appropriate ultrasound training, so you know how to screen, you know how to perform ultrasound, if there is a sufficient informatory to provide comprehensive counseling, and if there is an access in appropriate diagnostic techniques. For instance, if you know how to perform a CVS, you have to refer the patient somewhere else. If you don't know how to counsel a patient, and you screen the patient, you have to know how to counsel patients. So you need all this if you want to screen patients. So in the first trimester screening for malformations, you know that we started with maternal age, we moved to biophysical markers and TNB, ductus venosus, biochemical markers, and nowadays it's with NIPT. I'm not going to go through NIPT because my friend Pavel is going, tomorrow I think, he's going to present NIPT. So we know about nuchal translucency. I'm not going to go through that. Maybe you heard so many lectures about nuchal translucency. We know that it's the most efficient ultrasound screen, very dependent on technique and equipment, so you need an expertise, should be performed with adequate quality control, should be combined with serum, and this is very important also. Continuous audit of results should be in place. So, ladies and gentlemen, we know that concerning with an increased NT, good chances of healthy baby is 90% with nuchal translucency less than 4.5, 80% with nuchal translucency between 4.5 and 6.4, and also 45% with nuchal translucency more than 6.5. We know also that the group with increased nuchal translucency and normal chromosomal results, we have to look after malformation of the heart. There are some other markers. Yes, there are. There are many markers. There, for instance, in the nasal bone. That means that between 11 and 14 weeks, nasal bone is not visualized. And sonographically, in 70% in cases with Down syndrome, and in 1% with eploid fetuses. But now, ladies and gentlemen, we don't look very often nasal bone. This came down again. There are some other also markers. The incidence of absent nasal bone, because we don't use it very often because there is dependent on crown rub length, nuchal translucency, ethnic origin, and chromosomal defects. So it's not very objective. We know about, there are some other also markers, like fetal growth restriction, abnormal flow in ductus venosus, tachycardia, megacyst, abdominal wall defects, and single umbilical artery. I'm not going to go through all this. I'm sure that you know better than I what is meaning all these markers. But ladies and gentlemen, nuchal translucency and nasal bone or whatever, by ultrasound you have to combine with biochemical markers. And these biochemical markers is Papay and free beta ACG. Increase the sensitivity with the same false positive results. So the American College of Obstetricians and Gynecologists, for the screening program, must be with specific criteria. Training, nuchal translucency not alone, but combination of biochemistry, comprehensive genetic counseling, access to diagnostic tests, rigorous continual evaluation. So I think this is a key, is a message to take home. Don't perform only nuchal translucency. Combine nuchal translucency with some other exams, biochemical exams. I'm not going to go through this the non-invasive prenatal testing, because I told you Pavel is going to say that. But I want to say that all the bodies, American College, ISPD, genetics, they say that you cannot include NIPT alone in the screening. And you have to increase and combine first trimester screening with nuchal translucency plus biochemical tests, Papay and free beta, with NIPT in order to increase your sensitivity. And this is a formula from the people in King's by Kypros Nicolaides, say that you can combine the test. And you have to screen first by nuchal translucency, material age, and serum ACG and Papay. So if the risk is high, which is only 0.5% of the cases, you perform an invasive test. You don't do anything else. If the risk is low, which is 87% of the cases, you don't do nothing. So in cases that you have a moderate risk, you perform an NIPT. And if there is positive NIPT, you perform an invasive test. If it's negative NIPT, you're doing nothing. So if you have this in mind, you can control all patients, and you're going to have a great sensitivity with a very low false positive rate. So, ladies and gentlemen, we obstetricians, we start performing nuchal translucency. We had getting experience with anatomy of the fetus during the first trimester of pregnancy. And this is very important because we examine 1,200, something like that, fetuses during the first trimester, according to a protocol: the heart, abdomen, abdominal wall, extremities, placenta, cord, head, neck, face, spine, and chest. And what we found? We found that examination of fetal anatomy, including the heart, is visible in a routine test, in a routine scan, between 11 to 14 weeks. Completeness of examination depends on maternal habits and gestation. Optimal gestation beginning of 12 week and the end of 13 week. And remember, this week is that week that you perform a nuchal translucency test. And also access to transvaginal scan essentially in completed examination. And 11 to 14 weeks, and this is very important, can be the first anomaly scan for the fetus. I'm going to finish very quickly. So, I'm going to show you some pictures during the first trimester of pregnancy concerning the new equipments we have now for ultrasound. And you see the HD live silhouette and HD live flow. It's very, very important and the new technology, you can see so many things. You see 9 weeks normal fetus, 10 weeks. And genetic secondary sonography represents a group of sonographic findings which can be degraded in the score-related test. We know, everybody will know the sonographic findings for Down syndrome, the minor and the major structural anomalies and the non-structural anomalies. We know that the structural anomalies as these, they are combined with chromosomal abnormalities, and the several markers identified the second trimester ultrasound are associated with increased risk of Down syndrome. Ladies and gentlemen, during the second trimester, there are some lethal anomalies, moderated to several anomalies, and relative minor abnormalities that you can be detected by ultrasound. But the sensitivity of ultrasound in detection of structural defects is increased with gestational age, with the indication, with the experience of examination, which is very important, and with the fetal position. But every time you perform an ultrasound test, you have to inform the patient that 2 to 3% is the baseline and the baseline rate for major abnormalities. And information that 1/3 of major anomalies cannot be detected by ultrasound. The lateral ventricles with a new technology, an anterior fontanelle in 16 weeks with a new technology. And so the majority of abnormalities diagnosed in the second and third trimester will not be detected in the first trimester. So it's not true that during the first trimester you have the first anomaly scan. You have to combine first trimester and second trimester of pregnancy. So we know that about preterm labor, which is the major cause of perinatal mortality. We know that biophysical markers, like measuring the cervical length, is a good predictor value for preterm labor. And also we know that the shorter the cervix, the higher the incidence of having a preterm labor. We screen for preeclampsia, but Pavel is going to say about that. But the combination of history, biophysical and biochemical markers, you increase your detection rate for studies for preeclampsia. And you see, if you combine all these tests, you increase your sensitivity rate up to 90% of predicting the mild preeclampsia. But ladies and gentlemen, for this, all this, you need education. May I have 2 minutes, please? 2 minutes. The only way to achieve all these goals is a revolution in teaching the subject. So you have, and I heard that yesterday you had a very good course on ultrasound. You need it, because many practitioners were tempted to enter the business of BGYN sonography because, unfortunately, in many countries, no credentials were required. And sometimes there are people that perform ultrasound, they don't have even a diploma to perform an ultrasound. So we need to have education. Today, scientific societies formulate guidelines. Guidelines, we don't know whether these are followed in teaching programs or still remain on papers. But I think what titles are needed to access for the training programs and what should be structure of these programs. It's not possible or adequate to perform prenatal diagnosis of fetal anomalies without necessary knowledge of anatomy, monitoring of high-risk pregnancy without knowledge of obstetrical pathophysiology, and evaluating of pelvic masses without oncological and gynecological knowledge. So, ladies and gentlemen, I think if you want to organize a course on that, you need to be obstetrician first. So, the interpretation of sonographic data requires obstetrical and gynecological background, but also create integration of clinical instrumental. So, the requirements for center, you see this, and you have to have a practical part and theoretical part, specific hours for each part. The first level course and the second level course, and the first level and emergency can be attended by obstetrician, midwives, technician, and radiologists. By the second level for fetal anatomy has to be only obstetricians. And I finish with 2 slides. Let's say that we have to formulate teaching programs and structure teaching methods. And also we have to dedicate time and resources to train new generation of sonographers. And I have to congratulate my friend Dia for organizing a pre-Congress course on ultrasound. So in conclusion, systematic approach, familiarity with normal fetal anatomy, familiarity with sonographic landmarks and normal variants, head to toe. Develop your own approach, relationship of head and spine, documentation, which is very, very important, and continuous medical education and training. And also, you have to counsel mother and the couple. You know, ladies and gentlemen, it was 36 years since screening of neural tube defects became possible, and 29 years since screening Down syndrome advanced beyond the use of age alone. Screening has had significant influence on obstetric practice and improved medical care. Today, nearly all neural tube defects pregnancies and 9 out of 10 pregnancies with Down syndrome can be identified, and only 3% required invasive diagnostic test. And you have to remember that many years ago was 5 to 6% that they used invasive techniques. Thank you very much for your attention. Thank you. Sorry for the delay.
Aris, thank you for your excellent lecture. I think it's open for discussion. And please, there is a question. Do you have a mic for the lady? There is behind the camera, there is a lady with a question. Please stand up if they can't see you.
Thank you, Doctor, for the valuable presentation. Regarding the high knuckle translucency, as you mentioned, it could present a normal chromosomal fetus with isolated cardiac malformation. So do you recommend to do ductus venosus in Doppler in first trimester in cases of high knuckle translucency to
Can you repeat, please, because I cannot hear very
okay.
well. The microphones are very good.
You mentioned that high NT could present a normal chromosome fetus in case of isolated cardiac malformation. He could present isolated fetal with cardiac malformation could have a high NT, although the chromosome is normal. Do you recommend to do ductus venosus Doppler in first trimester for those with high NT?
tell you, I think that in cases that you do have an increased nuchal translucency and you perform a CVS, for instance, and you see that the chromosomal you have an euploid fetus. So it's better to wait until 18 weeks or 20 weeks in order to perform from a specialist cardiac to examine the heart. Because there is a good correlation between increased nuchal translucency, normal chromosomal abnormalities, and cardiac defects. So in all cases, you try to diagnose cases with heart malformations in case that you have increased nuchal translucency.
I mean, there is no rule for ductus venosus Doppler in first trimester in this case?
No, we don't perform Doppler in the first trimester of pregnancy. We try to avoid that.
Thank you.
Some more questions? Some more questions? I think it's quite important, Aris, that you mentioned the need of organization, because everybody who does the prenatal screening has to follow certain organizational system or logistics. It means when you see the patient, you must know what to do when you make a finding, where to send the patient, how to, if you say A, like you find something, then you have to say B. So this is very important, and this will be different in different setups. So every doctor and every doctor who is doing screening should follow certain system. And I think this is what you mentioned.
I think, yes. I think that if you do have an ultrasound equipment at your office, you have to be well trained to perform an ultrasound. I think you are going to be in troubles if you don't know how to perform an ultrasound and you have the machine, the equipment, just to show that you have an equipment and you perform an ultrasound, just to hear the fetal heartbeat, for instance. So, because you perform an ultrasound, generally doctors in Europe, they perform an ultrasound during every month that they see a patient, and at the end, on the 18 to 22 weeks, they send to a special center just to perform a second-level ultrasound test. And also to pick up some malformations, and then to say that, okay, I didn't know that, but I refer the patient to somebody else. Ladies and gentlemen, there are so many, I didn't have the time to explain to you very carefully. There are so many malformations you can pick up during the first trimester of pregnancy. And if you perform an ultrasound, you have to pick up all these malformations. I cannot say that you can pick everything, but there are so many malformations that you can pick up during the first trimester. So you don't need to proceed the patient during the second trimester in order to pick up malformations. I've seen women with anencephaly to go during the second trimester in order to pick up the anencephaly. This is unacceptable. And also, you maybe have some legal problems, because I think that if you perform an ultrasound, you have to know how to perform an ultrasound test. Otherwise, don't do it. I don't know how is the legal process in Bahrain, but I can tell you that in Greece, it's very strange. There are so many doctors go to the court because of all these details. So I think that you need dedication. And this is why I would like to, again, to congratulate Professor and my friend Dia for organizing this course. You need courses in order to pick up malformation and screen for pregnancy. Thank you.
Aris, thank you. We have to proceed.
Now I'm calling Dr. Nicholas Brachnes, who is Assistant Professor of Obstetric and Gynae in University of Athens in Greece, and he is honorary consultant in St. George's Hospital, London, UK. And he is going to present an important topic in our region, which is really gestational diabetes, an update. Welcome.
Thank you very much for the invitation, the Arabian Gulf University, and Professor Rizk and the organizing committee. So it will be really an update. This update concerns the years 2018 and 2019, what things happened and we should know so as to improve our daily practice. We have a chat about the prevalence and consequences of gestational diabetes, the new insights in pathophysiology, because if we don't know the pathophysiology, it's difficult to think and expect what is going to happen in the years to come, and the current guidelines on the management of gestational diabetes from 2018 onwards. So, gestational diabetes is a diabetes diagnosed only in pregnancy, not before pregnancy, in the second or third trimester, and it is a common endocrine disease. It is an epidemic, I would say, because the incidence worldwide is 17%. There are reasons for that, like the advanced maternal age and obesity. The clinical practice management is unsatisfactory. This is how we get so many babies overweight in cases with gestational diabetes. And there are plenty of guidelines which their presence shows the different approach and that we are not still getting to the ideal guidance by the committees. So we see here various continents and what happens. The first column is the year 2010 and then 2030. The Middle East and North Africa are about in the middle. With orange color is the intolerance in glucose, and then in blue color the diabetes mellitus. So you see in the Middle East, in the year 2030, you expect the diabetes and the glucose intolerance to increase, and the champions now are coming, is not Europe anymore, it was in the past, are coming the Southeast Asia and the Pacific, the Western Pacific area. Some data on the next chart from the UK shows how it is rising during the past 20 years, the gestational diabetes. So why it is so hard to treat this condition? So as soon as the pregnancy progresses, there is a pancreatic beta cell dysfunction, and the insulin is getting more difficult for the insulin to enter the cells. And this is where we focus in the molecular mechanisms that we are trying to elucidate as much as possible so as to be able to develop new medications beyond the other interventions that I will discuss later in the guidelines. So there is, apart from the pancreatic dysfunction, liver dysfunction, and the updates for these 2 years were related to how more understanding how adiponectin and leptin works, and how the inflammatory cytokines block the entrance of glucose in the cells, and hyperglycemia is a bad thing for the mother, because her pancreas becomes working in a more dysfunctional way, and bad also for the baby because all the glucose passes the placental barrier. So also there is a pro-oxidants and antioxidants imbalance, and then the oxidation process takes place and the metabolism gets irregular. Also there are issues that we understood related to the microbiome of the bowel, and also more understanding about the role of the placenta. So concerning the beta cell dysfunction, you can see how many different processes are affected and are related to insulin in gestational diabetes. Very, very interestingly, if you had a fetal growth restricted fetus that is female, evidence showed these years that it is very likely to get gestational diabetes later in life. This has to do with the different, obviously, hormone profile of women compared to male fetuses. Also, the low birth weight is an increased risk for diabetes later in life, and not only diabetes, but also hypertension in adult life, and prematurity also leads to diabetes in later life. So all these things we were able to understand better. Now, this figure may look complicated, but you can see in the middle the insulin receptor, and on your left-hand side, you can see how adiponectin promotes the entrance of insulin in the cell, and that means less insulin resistance, and how inflammatory cytokines, this is the second column on your left-hand side as you look the screen, so how these cytokines inhibit the entrance of insulin, so they make insulin resistance. So say, if you have a case with threatened preterm labor and preterm labor, obviously there are plenty of cytokines there, so the insulin resistance, say, is increased. So these things are blocking insulin, and the substrate that then gives the signal inside the cell to the gluta that you can see on your right-hand side to enter the glucose inside the cell. That is the far column on your far of the screen. So this gluta is not working, so the insulin is not coming in the cells. So if the insulin is not coming in the cells, what happens? Hyperglycemia. And what is the next step? Then this is a very toxic environment for the pancreas of the mother and the baby, and how the cells work. So insulin resistance happens something else, the placenta. The placenta starts producing an abundance of hormones, among them the placental lactogen. If you are going to remember one hormone that the placenta secretes and is related to gestational diabetes, is lactogen. And why is that? Because the placenta after 24 weeks secretes too much lactogen. And how this is related to our daily practice? It is related because we do the GTT test up from 24 to 28 weeks. Because earlier, the placenta is not large enough to secrete the placental lactogen, and by testing the women earlier with the GTT test, we are unable to check if this woman later is going to have either glucose intolerance or gestational diabetes, where two criteria are required. So new knowledge is that there are some glucotoxicity on the cells because the insulin cannot enter, and then the glucose stays free and circulates around, and this is very toxic for the cells. And then other signaling failures like the reduced adiponectin that is present here. So the insulin cannot enter the cells because we want plenty of adiponectin, and then the saturated fatty acids also inhibit the entrance of insulin in the cells together with inflammatory cytokines. So saturated fatty acids, what tells us? It tells us how we have to control mothers with the right diet, because there is no treatment for saturated fatty acids that can be that effective. So other neurohormones that work the same way like insulin is leptin. Leptin is produced in gestational diabetes, is increased, so there is what we call like hyperinsulinemia, hyperleptinemia, and also there is a sort of leptin resistance with similar mechanisms. So the reduced adiponectin the increased leptin, all these things cause hyperglycemia. And we learned in 2018 that there is another thing, that there is an adiponectin gene methylation in the placenta. So the genes get this abnormal function because of this process called methylation. And again, there are other issues like the glucotoxicity that is part of the metabolic dysfunction and also comes also from the liver. And we can see here the various adipokines and how they affect the glucose intolerance in a woman or the gestational diabetes. And we see adiponectin and leptin on your right-hand side that we have clearly understood or better understood their mechanism, and on the other hand, other adipokines like resistin and visfatin that their role is not clearly understood as yet. So there is some oxidative stress going on there because in gestational diabetes we have increased macrophage. Increased macrophage means increased inflammatory cytokines. And then this hyperglycemia produces a lot of oxidative stress, means a lot of oxidation, and then the glucose cannot be inserted in the cells and is moving freely, causing all these toxic effects. So how that is related to our knowledge and the latest data? Latest data says that we should be cautious with iron in pregnancy, not over-treating women with iron in pregnancy, especially the ones with gestational diabetes. I'm not talking about the anemics. I know I'm talking with women with reasonable hemoglobin. And why is that? Because this increased iron or folic acid that is taken after 16 weeks in a woman that does not need this folic acid, these things can cause dysregulation and hyperglycemia. And also, we know because the selenium and zinc, which is very useful, and they are found in chicken without using the skin, obviously, when consumed, or fish, or say nuts. These selenium and zinc and tuna fish are very, very important, and we should advise patients with gestational diabetes to consume those foods because these are preventing oxidation. So there are things that we should keep in mind and things that are coming from research that later will be, be used and be common practice. And again, in the liver is working with a process called gluconeogenesis, a lot of glucogen there, and obviously that is toxic for the pancreas as well. Concerning the gut now, the bowel, the issues related with the antibiotic use make the gut more permeable, or the diet composition if we are consuming too much meat, too much fat, too much fatty acids, or the reduced breastfeeding, which sets the metabolism in puerperium in a different mode, or preterm delivery with the inflammatory processes. All these things called insulin resistance, and this is how the gut reacts and sends many, many inflammatory mediators in the woman's body, and then this glucose intolerance gets worse. And obviously the role of the placenta, that we talk about the glucose, the glucogen that produces earlier, and other hormones and cytokines. Placenta is producing lots of hormones and cytokines. These are contributing to insulin resistance. So as you can see there, with the pancreas in the middle, even the brain, even if the appetite is increased because of the dysregulation from adipose tissue and from liver with neoglucogenesis, and how the gut permits inflammatory mediators produced by the gut microbiome to enter the circulation, and the placental cytokines and other hormones and how the muscle causes oxidation procedures. All these things explain who are the mechanisms for gestational diabetes mellitus. If we are not able to understand these mechanisms, we cannot have a considerations what drugs, what medication we are going to see in the future. Now, moving to more, day-to-day things to us, as you are aware, there are risk factors to develop gestational diabetes seen on the screen, and we are very familiar with those. HbA1c is not helpful according to a guideline in order to detect gestational diabetes. Now, the OGTT test, the oral glucose tolerance test, from 24 to 28 weeks should be 75 grams. This has been confirmed in last year's guidelines and should be at 0, 1, and 2 hours. But in high-risk pregnancies, this can be considered from the first trimester. The ACOG two-step approach is the one with the 50 milligrams that we check twice, and then they go to the OGTT test, the pathologic cases, but the women showed to have less compliance in these cases. So the diagnostic criteria were first discussed by these studies, as you can see, in 2010. Then from 2013, these criteria were very well established, the criteria that follow, and you can see on the screen. These criteria were very well established in practice, and 2019, we still follow these criteria in order to screen for gestational diabetes, and we should all have these values in our mind. Now, obviously, if we don't treat gestational diabetes, there is a risk for shoulder dystocia or increased intervention, like use of syntocinon and other interventions like venous delivery. There are long-term effects, both on mother and child, cardiovascular, like hypertension, obviously diabetes later in life, and the carcinogenesis, especially in female women, and babies related with endometrial cancer or even ovarian cancer and breast cancer. So the latest data are related to adaptive mechanisms. The babies secrete in their brain, that was a publication for my group, brain-derived neurotrophic factor, which tries to regulate this very, very abnormal environment, and that minimizes the risks concerning the regulation of glucose. So it is very important in a gestational diabetes to interfere either with diet or medication, because if we treat, even if it is mild, we have effects. You see in this study that how much all the conditions related to pregnancy are reduced, like preeclampsia, and other issues like microsomia and breast trauma, and even the cesarean delivery rate in these women. Also, diet is very, very important. I will comment about diet in the next slide. Also, it is very important to ask our women with gestational diabetes to move. After they have their meal, they should walk for 30 minutes. That is an important advice that we should take in our practice, and ask these women to move for 30 minutes to walk, to have a walk, and it is very, very safe in pregnancy. And obviously, no medication is as good enough if we need to treat as insulin. Certainly, metformin has its place, which is a class B medication, and gluburide also has its place. But there is less experience on this medication. But no medication, if we need to treat, is as good as insulin. And obviously, the combination of these three drugs exist in our day practice. Now, how you advise when you see in the outpatients your pregnant woman with gestational diabetes. Yes, we have to spend time to advise about walking, to advise about diet. And as you can see here, half of the plate of each meal should be really green vegetables, and the rest of it should be either chicken or fish, and you cannot see other meats included there, or carbohydrates. And obviously, avoid to take too many refreshments during pregnancy. So monitoring in women with gestational diabetes should be self-monitoring 3 to 4 times a day. And you can see the levels for fasting glucose and 1 hour later after meal. And the aim for HbA1c, that should be less than 6. That is different from a screening test. This is a monitoring thing. And concerning congenital malformation, how we should scan these women. These women should have, there is a slightly higher risk for congenital malformation. This is 1.16. That obviously, if a woman has pre-gestational diabetes, the risk is much, much more increased, but we are discussing how we should screen these women. So a detailed anatomy scan will suffice by experienced practitioners, and we should really focus on heart, brain, skeleton, and genitourinary system. Concerning the fetal growth scans, that should be taken in diagnosed cases at 28, 32, and 36 weeks, and Dopplers weekly after 37 weeks, or if there are issues, we will initiate them earlier. So this is the approach. Concerning now the timing of delivery, you can see how initially I started my presentation, that there are so many guidelines from various very respected groups that recommend different dates set weeks of delivery. And obviously the complicated cases, that will be after 37 weeks, like in the pre-existing diabetes. But I will comment about the uncomplicated cases, which is the bread and butter of our cases. So if it is diet controlled, the induction of labor should really be at 40 weeks. And if it's not, it is medication controlled, then the induction of labor should be at 39 weeks. And if the estimated fetal weight is more than 4.5 kilos, then we should go for cesarean section. So these are the guidelines from 2019. And here this slide shows how important it is to induce these cases with medication early in order to prevent mortality in babies. So the postpartum care, again, she needs to have an OGTT, 4 to 12 weeks postpartum with 75 grams. And you can see here, if the women follow our advice, and our role is very important in the puerperium, how much they can decrease by lifestyle modifications, 58%, the appearance of diabetes later in life, and how much by metformin only without lifestyle modifications, 31% the appearance of diabetes later in life of these women. So our role does not stop with gestational diabetes on delivery time, but carries on when we see them postpartum and give these advices. So there is beta-trophin and lipacin, a new peptide hormone that is coming up as a therapeutic target. That is 2019 knowledge. And also we have understand that there is an autoimmune B-cell dysfunction, and the anti-GAD antibodies is the same how the antithyroid antibodies work, is the same mechanism that has now started developing in the liver. So GDM is a metabolic dysfunction. To conclude, there is no cure at the moment or efficacious prevention strategy. We try to understand all these molecular mechanisms in order to treat. So consistency of the guidelines should really improve, but in the meantime, we should follow up these guidelines, the existing guidelines, so as to have less adverse outcome in our labor world. Thank you very much.
Thanks. Now the floor is open for discussion.
Right. It is very, very important to focus on dietary advice, make clear in our mind that gestational diabetes without treatment is different from gestational diabetes with treatment concerning the time of delivery. Make clear in our mind that these babies has less anomalies compared to the women that start their pregnancy with insulin and diabetes, and focus very much to these diet issues.
Doctor, for the patients who have polycystic ovarian syndrome, which is very prevalent here in the Gulf, and many people conceive on combinations of metformin with clomiphene citrate and things like that, is it advisable for them to keep taking the metformin to prevent gestational diabetes?
Metformin as prevention is not working in my mind. Why? Because I don't know that this woman is going to have gestational diabetes. Is a diagnosis afterward. Metformin on its own will, if the diagnosis is set, and I have correctly understood your question, will help in pregnancy, but each pregnancy is different because you can see there are so many different processes, so metformin may not be adequate. So if metformin may not be adequate, that we usually start with 500 milligrams, and we can go up to 2,500 milligrams depending on the case, we may decide either to add insulin with metformin or to add gluburide, which we usually start with 2.5 milligrams, but if it is a combination with metformin, we start with 1.25 milligrams. So we can use all these things, and obviously the result will be shown on the woman's glucose levels, fasting, and 1 hour after her meal.
Thank you.
Thank you.
Thank you very much.
I had one question, but later on I will ask you. Okay? Because for the time, because now it is already over, I will ask you one question later on. Okay. Now I will call my colleague, Professor Calda, to give a presentation on screening and prevention of preeclampsia. Professor Calda is working in Charles University. He is the head of Fetal Medicine Center in Prague, Czech. You are welcome.
Fantastic. I'll try to go back. Perfect. First of all, I would like to thank the organizers for the kind invitation, and I'm really impressed by the number of attendees and about this fantastic setting. So thank you so much for the invitation. I am really honored to be my first time in Bahrain. I will try now to bring more answers than questions. Many of the speakers today raised many questions, and I think I will be able to bring more answers than questions. My task will be to convince you that preeclampsia is an existing disease, that it's important, that it's frequent, relatively frequent, but very important, and that we have a possibility to prevent it, and that we are able to do it very efficiently. I come from this old hospital, which has been built in 1875, already as a maternity hospital in Prague, in that time designed for 3,000 deliveries. Nowadays, we have up to 5,000 deliveries, and it's still functioning. And it's one of the oldest maternity hospitals in Europe. Well, I hope that the situation in Bahrain is much better than in Europe and than in my country. Czech Republic has a population of 10 million inhabitants. Former Czechoslovakia had 15 million inhabitants. Unfortunately, our population of pregnant women is getting older and older, and the trend of postponing pregnancy is really prevalent in the last 10 years. We have more than 20% of pregnant women older than 35 years, and the average age of getting a first baby is now 30 years, which is, I would clearly say, it's a disaster. Most women have just one child. The natality is 1.4, and of course the number of pregnancies from assisted reproduction is increasing. We are dealing with women with a major health burden. We have patients with after transplantation. We have patients, they are quite sick, being 35 to 45. And still, we are not able to improve the preterm delivery rates, which we are trying to, but we are not very successful like nobody in the world, which is still on the same level. Generally spoken, the quality of the population decreases. This is how it is in the graph. You can see that since 2002, the number of women getting older and older is steadily increasing. What it means to be older, it also means that the risk of pregnancy complications is increasing, and especially preeclampsia and miscarriage, and also the frequency of small gestational age is increasing in mothers over 40. When we talk about prenatal screening and when we talk about topics how to improve the pregnancy care, it's necessary to clarify who are the enemies of pregnancy and what are we fighting against. These are the real data from our statistics, from the national statistics, where we can see that on one hand, 84% of pregnancies does not need any care because they are completely physiologic. On the other hand, 16% of pregnancies are sick, and only 8% have a specific cause. The other 8% is a long number of very, very low frequent diseases. And what are the frequent ones? These are hypertensive disorders, hypertension, preeclampsia, and eclampsia, and I'm now trying to talk about these topics. It is, unfortunately, the incidence is different in different parts of the world. In Europe, generally, the frequency is relatively low, about 2%. But there are countries where the frequency is even much higher, like up to 8%. When we know today that we are able to detect or to identify those with the risk of preeclampsia already at the end of the first trimester on the first trimester combined test, which has been postulated by Kypros Nikolaides years ago for aneuploidy testing. But today we know that this is a part of so-called turning the pyramid of prenatal care, where we can screen for the risk of a bunch of conditions like miscarriage and fetal death, fetal growth restriction, preeclampsia, preterm delivery, macrosomia, gestational diabetes, and not only aneuploidies. So this is why it's important to screen in the end of the first trimester. We know, I think I don't need to convince you, that preeclampsia has a major impact on maternal health. Those with preeclampsia have about 5 times higher risks than those without preeclampsia. And what is quite obvious that also the neonates are impaired by preeclampsia because they are delivered too early. Nowadays, we know that we do not want to deliver neonates before 34 weeks of pregnancy because the risk of these pregnancies is higher than after the 34th week. And postponing preeclampsia after the 34 weeks is crucial. Again, the impact on neonatal health is, on the fetal health is quite obvious. It's about 3 times higher risk in neonates than in those not having, those mother has not preeclampsia. You know that over the decades, there have been collection of new and new information about preeclampsia. And this is how we changed the definitions of preeclampsia, and that we today are mostly using the causal definition, where preeclampsia is the placental for the early preeclampsia, or cardiovascular, mainly affecting the third trimester pregnancies. So this is not only early, intermediate, and late. And as years ago, we used the definitions regarding severity. Preeclampsia is actually a metabolic and cardiovascular stress test for the pregnancy, where the mother is cardiovascularly impaired. So those mothers who develop later in life cardiovascular problems, they might be candidates for preeclampsia in their pregnancy. Pregnancy might be seen as a transient proaterogenic metabolic syndrome, which in those with the risk of developing cardiovascular disease later in pregnancy might be, these mothers might have preeclampsia already in the pregnancy. What is quite interesting is how does placental disorder explain long-term cardiovascular morbidity with preeclampsia? We know that those mothers who develop preeclampsia in pregnancy have a shorter life expectation than those they have a physiologic pregnancy. This might have a connection with the precondition of cardiovascular disease later in pregnancy. Well, we know a lot about pathophysiology of preeclampsia, despite we don't know the real cause. We are not yet so far that we would know the reason of preeclampsia. We know it's placental dysfunction, it's a vascular compromise, and there is an end organ damage. And we know that it is the failure of transformation of the spiral arteries which causes the placental cause for preeclampsia, for the early preeclampsia. And the placental transformation, the transformation of spiral arteries is completed by 16 to 18 weeks. So when we want to act, when we want to prevent, we have to start before 16, 18 weeks. So this is the introduction, and now about the screening for preeclampsia. So we know that we have a population with a low risk population, and we are trying to identify those who will develop preeclampsia, who might be affected by a preeclampsia, and who might profit from prevention. As you have seen this slide here already, there is an approach combining maternal history, biophysical markers, and biochemical markers. And altogether, this allows to calculate the risk of preeclampsia. It is the part of the pyramid of prenatal care, as I have already told you, and most of you have heard about it, how this is provided. In the first trimester, we examine the biochemical markers. We measure the blood pressure of the mother, and we are measuring the Doppler indices in uterine artery. Through this method, we are able to detect the majority of cases on a very low false positivity rate, let's say 10%. This is what is known for, let's say, 10 years now, but there are some clues in this workflow. It is very important to properly measure the blood pressure. I do remember when our nurses were measuring blood pressure by palpating radial artery, which is, of course, a nonsense. We have to measure on both hands twice, and we should use a proper size of the cuff, because some women are very thin. On the other hand, there are women who are quite big, and they need different sizes of cuffs. And we need to achieve or to get the average of the measurements. If you try yourself to measure the blood pressure at yourself, you will see that each measurement you will get different numbers. So to obtain the right numbers, you have to repeat it twice on every hand after 5 minutes, at least 5 minute rest. Let's say the women may not run to your office and being measured immediately. Again, measuring uterine arteries, the Doppler of uterine arteries, many doctors are afraid of it. It's a very simple measurement. We are able to teach it everybody in, let's say, minutes, not hours. If you have already done ultrasound, to recognize uterine artery and to measure the Doppler is not a difficult task. So this is the part of the measurement. You can combine all these methods and you will get different false positivity rate and especially different detection rate. The best detection rate is achieved with measurement of the maternal arterial blood pressure, uterine PI, PAP-A, and PLGF. I will come back to that. So, we know that if we apply aspirin to those who are defined as at risk, we are able to decrease the risk of preeclampsia when we start before 16 weeks. There was a big question how much aspirin to use. We know that if we use not enough, there is something like aspirin resistance, and we should not use less than 100 milligrams per day. If we use more than 150, there might be too many side effects. So 100 to 150 milligrams is the right amount. The game changer was the ASPRE trial, which has been published in 2017, where all these smaller studies have been brought together to a prospective, blinded study, randomized study, and this study has shown that quite a lot of information. What I would like to mention is that when we give aspirin to our patients, we need to give it in the evening. There is evidence that giving aspirin in the evening is more efficient than giving it in different times of the day. This was the study which I will come back to that. I just would like to say that when provided properly, we are able to decrease the number of preeclampsia before 34 weeks, which is the crucial time, by 82%. 80% is a fantastic number. So it's really worth to do it, and it's sad not to do it. So decreasing the risk by 82% in the highest risk group is the main goal or main achievement of this screening. Why to give? Well, why to screen? Many times we get a question, why not to give aspirin to everybody and skip the screening? The problem is that even in this trial, where the women were informed and motivated to take the aspirin, the compliance was not that big. Only 71% of women took more than 90% of tablets in the trial. If you give aspirin to everybody and tell a woman at 12 weeks, you should take aspirin till 36 weeks, they will not take it every day and they will not be motivated. This is the first reason. The second reason is that in this study, it has been shown that there might be hypersensitivity to aspirin and there might be women with peptic ulcer bleeding disorders. So it is not a completely harmless drug for the women. It should be very harmless to the baby. But some of our patients will not tolerate well even these 150 milligrams of aspirin. So this is about the trial. We can conclude that it's the effective screening and prevention of early onset preeclampsia is possible by first trimester combined test and preventive dosage of 150 milligrams per aspirin prophylaxis. And this strategy might decrease the perinatal mortality and morbidity especially because the babies will not be delivered preterm. Another question is, if we really need to perform that expensive screening with PLGF, placenta growth factor, which costs something. Actually, there might be a low-cost setting using just maternal characteristics and maternal blood pressure, which will not be as effective that the complete set of the screening, but at least will mean something. So you can start with this low-cost setup, and you can increase the detection rate by uterine artery measurements and by the biochemical markers according to your possibilities and according to the possibilities of the local economy. Well, I will skip that. So this is not a finalized product. So there are many future strategies regarding screening. There are studies using statins, for example, for prevention, but this is not concluded yet, so we cannot talk about it. And there might be new ways of therapy which are still in a research phase. So this is, again, a part of the research. There is a bunch of new potential biomarkers of preeclampsia being studied, not yet introduced in everyday practice. What is quite important, and this is the conclusion of my talk, that this very short and very successful strategy of identification, those who need the prevention, the possibility of giving aspirin, and decreasing the risk of preeclampsia, which now is about 10 years old since we started, actually, was suggested by FIGO guidelines in 2019 as a standard for each country, and it should be achieved in each country that there is a program for preeclampsia screening and therapy. You can download this flyer from the FIGO webpage, figo.org, and you can use it for your needs. Thank you for your attention.
Thank you. Now the floor is open for discussion. Any questions? No?
Everything is clear. May I ask you, who is performing preeclampsia screening in this room? Who of you is doing preeclampsia screening? Nobody. Nobody is doing preeclampsia screening. You. One. Greece. Please think about it. It's simple, it's very effective, and it is really changing the game. Please, there is a question. There's a question, please.
Thank you for the great presentation. Is there any cutoff for different ethnic groups for the mean arterial pressure?
I'm sorry,
Is there any cutoff for the mean arterial pressure for different ethnic groups?
I will try to go here because there is a problem to hear you. Can you repeat it again?
Is there any cutoff for the mean arterial pressure in different ethnic groups?
Oh yeah, thank you. Actually, I don't know it. I don't know if somebody here knows it. We are using the software which is delivered to us by, there are, I think, 3 worldwide softwares like we are using. I have no conflict of interest. I have nothing to do with the companies. It's Astraya, it's Viewpoint, it's FedView. And if you examine the patient, you just click on his race. And if you click on his race, the computer does it for you. And I don't know if there are cutoffs for different races. If there are in the system, but we could check it. I think there are not racial differences, but I am not sure for that. I can check. I am not sure. I think it's not, but I cannot answer clearly this question. But if there is the difference, the software should do it for you. You definitely need a software when you want to calculate the risk. Regarding the software, you don't need to pay anything for the software. You can go online. There is software on the FMF page, fetalmedicine.org, which is FMF, so our in Barcelona group has a software. So, and you can use it online. You just put the data in the online, and it calculates the risk for you for free. Or you buy the software. But without software, you cannot calculate it on a calculator. It doesn't work. Thank you. Any other questions? No. Thank you.
Thank you. Now I will ask Dr. Dalia Hamdan to come to the stage to present her topic, Pregnancy of Unknown Location, Management Options. Dr. Dalia is a consultant obstetric and gynecology at Salmania Medical Center, Bahrain. She had a fellowship from Australia in advanced laparoscopy, and her main interest is early pregnancy loss. Thanks.
Good evening. Thank you for staying till this time. It's been a long day. I come from Salmania Hospital, which is a tertiary hospital in Bahrain, the biggest one, with 900 beds and 6,000 to 7,000 deliveries annually. And I had my fellowship training in Australia Nepean Hospital, working with Professor George Condas. He's interested in advanced laparoscopy and early pregnancy. So what is pregnancy of unknown location? It's a descriptive sonographic term applied to women with positive pregnancy tests who have no evidence of either intrauterine pregnancy or ectopic pregnancy while doing a transvaginal scanning, okay? So we are emphasizing on doing a transvaginal scanning in this group in order to label them as PUL. The term is a classification and not a final diagnosis. In this group, the prevalence, or in the literature review, the prevalence of PUL by TBS is around 8 up to 31% of women. And in the hand of experienced sonologist, okay, or a sonographer, it ranges between 8 and 14 of women, which will be later on diagnosed as ectopic pregnancy. Why ectopic pregnancy? We need to diagnose from the first visit. It is a leading cause of maternal death and in the first trimester and can be associated with significant maternal morbidity. Up to 90% of clinically relevant ectopic pregnancy can be detected at the initial ultrasound scan. This is a simple graph by Jerkovic in detection of ectopic pregnancy with the years. So if you are in the 21st century, you will have the 90%. Otherwise, you will be going backward, okay? So that's how to test your efficiency of early pregnancy unit. Condes et al. In 2006 they have done a consistent statement discussing the PUL group, and the panel believes that most modern units should keep the PUL rate below 15%. And in clinically stable women, we should not be going into aggressive treatment, but we should treat conservatively while working on the diagnosis. Majority of PULs represent a low-risk group, around 86 up to 92%. So, as I said, we should not do aggressive treatment, and this represents either a failing intrauterine pregnancy or ectopic pregnancy, which are never seen, visualized on TVS, which is called the failing PUL, or intrauterine pregnancy that are too early to visualize using TVS. So do we need to reach definitive diagnosis? You will answer this in the coming slides. So they have done like a classification of PUL. So in the arm of the USA group, they have been categorized these into 3 groups: intrauterine pregnancy, the outcome of PUL, intrauterine pregnancy, ectopic pregnancy, and miscarriage or spontaneous abortion. We know that the USA have an aggressive treatment as much as their politics, and we know that the American Society for Reproductive Medicine, they are practicing curettage in these groups to rule out ectopic pregnancy if the serum levels have gone beyond 2,400 and they did not reach into a definitive diagnosis. While the literature from the UK and European countries have stratified final outcomes into 4 groups. They are the intrauterine pregnancy, ectopic pregnancy, failed PUL, and persisting PUL. The role of biochemistry and math models were studied in this group, where first they studied the initial serum HCG level, which is later on found to be not predictive of PUL outcome. So a study which was conducted by Condes et al. Have made a diagnostic accuracy of varying discriminatory zones for the initial HCG level. That they have evaluated the accuracy, okay, for serum HCG level more than 1,000, more than 1,500, and the third group is when the HCG level is more than 2,000 to detect ectopic pregnancy. In the study, they included more than 5,500 women presented to APU between 2001 and 2003. And the PUL rate in this group, or in this study, was 10.3%. The prevalence of ectopic pregnancy was 8.7%. They have relied on ultrasound and not the routine use of curettage as the USA are practicing to rule out ectopic pregnancy. This approach does not only, it will not give 100% sensitivity, but it is safe and it is not invasive, associated with low false positive rate of 5.9%. They have made an estimation of 21 uterine curettage could have been done by the American in this study. So out of these, of course, they depended on the beta HCG level of 2,400 or more, okay? So if they have done this 21 uterine curettage based on US group, they and this group will be 10 in the failing PUL group, 7 in the intrauterine group, and 4 in the ectopic pregnancy group. This approach could have potentially terminated 2 viable ongoing pregnancies in the intrauterine group. So they have advocated, based on this study of the discriminatory zones, which were previously followed, that we should watch and see. Then came the HCG ratio, which is the HCG at 0 and 48 hours, which can define a failing PUL. They have done they give a cutoff value of less than 0.87 serum level, ratio, and it's a serum, that means it's a serum HCG fall more than 13% over the 48 hours. This will identify PUL who will resolve spontaneously and will not need any further intervention. In a study by Beniardi and the same group, they have done in another observational study included more than 12,000 women, and they have predicted the ultimate viability of intrauterine pregnancy of uncertain viability, which is the IPUVI, okay, in the pregnancy of unknown location, and it was calculated to be more than 2. In this group, they have done a 3 beta HCG level. So if the women have a 0 HCG level, and in the 48 hours there was an increase of more than 66%, then this woman will be included in the study. Then they will be followed, okay, with another, with a third HCG level, again after 48 hours. This lady will be considered a probable intrauterine pregnancy of unknown viability, and she will be given a scan after 1 week. And those who comes to this clinic after 1 week and they discovered an intrauterine pregnancy, they will decide viability if the CRL is more than 6 millimeter, as we know, and a presence of cardiac pulsation. If it is less than 6 millimeter and there is no viability, then the patient needs to come again after 1 week. If it is more than 6 millimeter and there is no cardiac pulsation, this is a failed intrauterine pregnancy. So they have, with this HCG ratio that we have used in the PUL pregnancy, now we have used it in another group, subgroup of the PUL, which is the intrauterine pregnancy of unknown viability, to predict viability. And the cutoff is 2. This is the does it contain? Anyway, so in the BTS, the failing PUL have an 89.3% HCG ratio of less than, if it is less than 0.87. But you can see in the ectopic pregnancy, it's around 15%. So those ladies who have an HCG ratio less than 0.87%, they're still at risk of having ectopic pregnancy. And if it is more than 2, as they have used for the viability, you can see that there is like more than 77% in the viability. But again, the ectopic have done also around 6% or 8%, sorry, HCG ratio of more than 2. So the women should be counseled again that if the HCG ratio more than 2, it is most likely to be an intrauterine pregnancy, okay? but there is still a very small chance of having an ectopic pregnancy. Another group have tested this same HCG ratio for the prediction of viability in the assisted conception cycles, and it was found to be 1.8. Similarly, or very near to 2, which was found in an earlier study. They have found it between day 14 and 16 after oocyte retrieval. If you will ask about the multiple pregnancy, how they are going to do if is it applied, yes, as according to Chick et al. In 1992, he found that in multiple pregnancy, the same ratio can be applied because there is also a doubling of HCG in this group. The same group, they have a very good statistician, Ben Van Classer, and he have done many studies with the math models, okay, with logistic regression models from M1 to M4, and it continues to M6, which I will slowly go with you to discuss its importance. So the logistic regression model M4, it used the initial HCG and HCG ratio at 48 hours, and they have based on a risk of ectopic pregnancy less than 5%. They have classified 70% of PUL as low risk, and with 97% being a failing PUL or intrauterine pregnancy. So these low risk group means I will not have to worry about a complication or a rupture or an intervention. And on the other hand, 88% of ectopic pregnancy were correctly classified as the high risk group. So they have to be followed very cautiously. When we talk about progesterone level, what about it? Is it have a role in the PUL? They have studied that initial serum progesterone level. And Joran Verhagen in 2012 have stated that a single progesterone measurement in women with early pregnancy presented with pain or bleeding with inconclusive ultrasound, i.e. PUL, can rule out a viable pregnancy. And this was a systematic review and meta-analysis of diagnostic accuracy using 26 cohort study, included more than 9,400 pregnant women. But if you check in the NICE guidelines in 2015, this was ruled out. It has recommendation, okay, as to against this, that not to use progesterone level to diagnose viability or non-viability. Another study done with the same group, okay, Ben Van Classer have leading this study. It has studied the managing of pregnancy of unknown location based on initial serum progesterone. So they have combined the serum progesterone and the serum HCG ratio, okay, with a two-step protocol. So in step 1, they have done an HCG level and a progesterone. If the progesterone level is less than 1, okay, then it is most likely or probable and a failed PUL, and these ladies no need to do anything to her but to come after 2 weeks with a urine pregnancy test, okay? And this will have also, of course, an impact on our health system. If the progesterone is more than 2 nanomol per liter, then go to step 2, which is repeat beta-HCG in 48 hours, and then combine this with the AP risk mathematical regression or the M4 regression model. They have calculated if it is the AP risk is more than 5%, okay, to be in the high risk group with a probable ectopic pregnancy. Then I need to repeat a beta-HCG again in 48 hours and repeat the TVS. Those who have made a less than 5% risk, they are, as we know, they are low risk, okay? And they are either considered a failed PUL or an intrauterine pregnancy. And they will be followed either by a 1 week time or 2 weeks in the failed PUL. The advantage of this, incorporating serum progesterone into algorithm with the two-step strategy, have discharged many patients after the initial visits. And this low cutoff value of progesterone means that only 2.9% of the ectopic pregnancy group will be misclassified as low risk at this first step. In the two-step protocol, they classified 62% of PUL as low risk with a negative predictive value of 98.6% and a very good sensitivity of 92. When the risk model was used in isolation, without the first step, they have made a 60% of PUL as low risk with 99 negative predictive value and 94.9 sensitivity. And that's when we are talking about the M6P, which is they have combined the M4 with the progesterone level. I will skip. So an effective strategy of selecting low-risk cases in which follow-up can be reduced to the minimum while directing resources to women at high risk of harboring AP, that was the conclusion of this study. So when we are doing, when we are dealing with a patient with PUL, we also need to think about our resources. So is there a need to definitively diagnose location of pregnancy of unknown location? The answer is no, okay? And that's a study done by the same group. They have done the cost effectiveness on the healthcare system, or the cost burden on the healthcare system, and they have found that minimum of 5 visits were the median for these group of women, okay, and the test or the definite diagnosis may take from 3 days up to 25 days. So they taken into consideration the number of visits per patient, scans, and blood. And if we are going into do an intervention, okay, which is can lead to a negative laparoscopy and morbidity for the patients in this group, this should be studied very carefully. So the practical points for good TVS scanning: effective APU service should be available for these women, okay, where consider them as high-risk pregnancy. It should need a well-maintained ultrasound machine, appropriate training for our staff, understanding of how to read serum HCG level, and how to incorporate these into the clinical picture. Initial serum HCG level in this situation do not contribute to diagnosis, but may assist in the management plan. Serum progesterone, as we said, has no rule other than maybe combining it for a study or research. Keep PUL rate to the standard level of 15% and below. This can be done by auditing in the APU service, and minimize the need for follow-up, number of interventions, and adverse outcome. Okay. So in this classification, I'll just go through again with you. The PUL classification is a low-risk and high-risk group. The low-risk combine the failed PUL and the intrauterine pregnancy. The first one need after 2 weeks. The second one will need after 1 week ultrasound, repeat scanning. The high-risk group is the most likely most likely to be ectopic pregnancy, or those classified as persistent PUL. If we use the HCG ratio, use it wisely. As we said, HCG ratio less than 0.87% may represent a failed PUL, and a HCG ratio more than 1.6 may be an intrauterine pregnancy. look into rare, when doing the ultrasound, please look into rare locations of the pregnancy, scar pregnancy, interstitial coronal C-section, ovarian pregnancy, and you may use a 3D ultrasound if it is available, otherwise MRI to reach a diagnosis. And that's it. You can see this, I'll just, you can see how complicated is the PUL in one of the NHS hospital. So it is really a burden on the health system, but it can be, we can reduce this by doing an initial scanning with by a good hand, okay? I quote this from another slide from Djurkovic. The PUL is a result of too early scanning, which is will later be intrauterine pregnancy, or it is too late because the patient have passed already the products in complete miscarriage, or it is too difficult because of abnormalities within the uterus, fibroids, etc., or too bad if it is an ectopic pregnancy, which we need to diagnose early. These are my references. Thank you.
Thank you very much for your comprehensive talk. I think we have another 2-3 minutes for a question and remarks. Anybody who wants to make a statement or question? I would like perhaps to say that the end was, in my eyes, the most important part of it, because we are all facing this problem in everyday practice, and there is a lot of research, especially the group of with Tom Bourne is doing published a lot of, but you know, they actually didn't come to many practical conclusions, that mostly any measurements are not very valuable, because if ACG doesn't say anything, because if it's too high or too low, well, perhaps too high is good, but too low means nothing. And ultrasound is also misleading. So I think it's very important to have experience, to have a system in your own setup, and to avoid unnecessary procedures. What do you think about methotrexate in that setup? Methotrexate, do you use methotrexate?
Yeah, I use it because we have a group of patients who have a relatively high HCG level, okay, with above 1,000, and they are plateauing, and there's repeated scanning is not able to make a diagnosis, and it is relatively plateauing, and the patient is stable. Then there is a role of methotrexate, which have also a good, as we said, there will be a group of patients which is less than 2% will be having a persistent PUL, and that's the group where we can use methotrexate.
Yeah, thank you. There's a question, please. Oh, well, there's a question for time for one question, and we can finish. Please. The remark, but do we have a mic, please? Before you get a mic, I just would state that using methotrexate means that you may not miss intrauterine pregnancy, which is very, very dangerous. So you must be absolutely sure that there is not an intrauterine pregnancy.
Yeah, you can wait till at
yeah.
least, you know, to make
please.
sure, as we
There's
said, watch and
last
see.
question. Yes, please.
No, it's not a question. It's just going through one of the literature.
Could you
It's
speak
a
to the
kid.
mic?
It's not a question. It's just going through one of the case report has been reported in the ASRM in July 2019. There is a role of the aromatase inhibitor for the patient who has ectopic pregnancy or unruptured pregnancy. I think there is maybe a role of using of aromatase inhibitor like Femara for the patient with BUL. Femara. Okay. In September 2018, there was a case report about use of the aromatase inhibitor like anastrozole and Femara for the patient who unruptured ectopic pregnancy with a side effect of methotrexate. There was only one reported case in US. They use aromatase inhibitor for this kind of cases. I think we may have a try to do kind of study for this kind of patient, persisting BUL, for the use of the aromatase inhibitor. Thank you.
Evidence-based. It's not, no. Unless there is a research, then. No, never. Okay, it's a case report.
We use it here in Bahrain for ovulation induction, and
Yeah,
sometimes we
but
are using to reduce the risk of OHSS. But I'm just talking regarding the BUL.
No, I'm sorry. Thank you.